Hi, my name is Mohamed Jaber. I'm a vascular surgeon in Southern California. We talked briefly last time about dissection and talked about aortic syndromes such as intramural hematoma and PAUs and management and so forth. Today we're going to talk about contemporary treatment of type B aortic dissection. Aortic syndromes we talked about last time, and they're clearly there's a basically disruption in the intima, and depends on the type of that disruption in the intima. As we spoke last time, you classify this. You have to understand that there is interchangeable terminology between the three of them, and the basically you can have a penetrating ulcer that turns into type B dissection, intramural hematoma that turns into type B dissection, about 20% or so of these, and aortic dissection. So aortic dissection, clearly there is intimal tear. We talked about penetrating ulcer. It's an ulcer essentially, and intramural hematoma just within the wall of the aorta. We talked about also briefly about dynamic and static obstruction. Static obstruction, where you have physical occlusion in the in the orifice of any target, any visceral vessels, renals, could be iliac, could be SMA, could be anywhere, and that's a physical intimal occlusion. Whereas static or a dynamic obstruction, it's usually as a result of the high pressure in the false lumen that pushes or compresses on the intima or septum, and that would occlude, as you see on the left hand side, what happened with that with the orifice. The dynamic obstruction most of the time just basically gets resolved by virtue of treating this the proximal intra-tear stenting that will depressurize the false lumen. Most of them results okay. They resolve. The static obstruction is sometimes it's required. Most of the time, it's required that we stent that or do surgical bypass or whatever necessary. So if you look at the type B aortic dissection from acute to chronic, the evolution of this is basically the most important thing is the septum becomes very thick, the false lumen becomes partially thrombosed. Sometimes people are lucky that gets completely thrombosed, but there's nothing changes in the size of the true lumen, which, as you see, the true lumen is very small here in this day 14 after 6 weeks, and you go basically all the way up to 4 years, and still basically still small false lumen, and that has implication. Especially I've seen people with claudication with that. I've seen people also asymptomatic with that. So this is the septum in the chronic dissection. See, it's fairly strong, basically, and it's hard to move if you with a stent usually, and a lot of times these patients would require open reconstruction or some sort of a hybrid reconstruction where you can. It depends on the size of the false lumen, etc. The old classification, Stanford classification and the Bakey's classification, they were useful for a while, but as the endovascular therapy evolved, and as we vascular surgeons and also cardiac surgeons, they do a lot of these as well, we have been doing work within the aortic arch. We had a lot more knowledge on the treatment of the type B dissection, or type, the relationship between type A and type B dissection, because a lot of times you start off with type A, but then you have type B, and you have to deal with that in a consequent time. So the nomenclature has changed, because the first classification is non-endo-intuitive. Intra-tear is not really recognized. Extent of the dissection not specific, and aortic arch involvement is not mentioned. carefully. This is a new SVS, which is Society of Vascular Surgery and Society of Thoracic Surgery. They sat together, they came up with this nice classification. This classification has been widely used, accepted. It's very specific, it's a very nice classification. Due to lack of time, I don't think we should waste time on this because it's self-explanatory. If you read this, if you type in aortic dissection classification system, there's a free download for that paper. It's in the Journal of Vascular Surgery. It nicely explains how do you read this. But I'll give you an example. If you look at the patient has type A dissection, so that would be a type A, and then type A classifies is all the way to the innominate, and then the arch down from the innominate to the iliac, that's type B. So if a patient with type A dissection, that extends to the iliac, so that would be A 0 to 9, and then there is no entry tear. So zone, basically, entry tear is, you look, there's no entry tear visible, that would be involved zone 0. So, and you write it as ID or something like that. So you have to practice with this, and I think it's self-explanatory. If there's any questions about it, I'm happy to put a little talk about it. But what we did with our fellows, they just read it, they understood it, it's self-explanatory. It takes a little bit of practice, but you must be familiar with this dissection if you want to do dissection classification, if you want to do dissection work. And also there are new high-risk features such as refractory pain, refractory hypertension, readmission, and these are new radiographic malperfusion, which I'll show you that what that does that mean in a future slide in this presentation. So the complicated type B dissection is simple. It's complicated. It's either rupture or malperfusion, really, and you have to fix them right away. Sometimes depends on the patient, how the patient presents. We've had patients that were very, very sick. We treated the malperfusion and then we left the dissection for later because they were very sick, and I've seen that a couple of times in my career. The society guidelines, I mean, they talk about a lot of there's really not much of a data in the way of randomized trials. So all the recommendations that you're gonna see, the highest is gonna be, level 2B, 2AB, or 2AC. So these based on registries, based on IRAD database, based on personal experience and so forth, because it's hard to randomize patients with acute dissection. They're so sick and you gotta take care of them. You can't just randomize them usually. I know for a fact that the Society of Vascular Surgery, they're working on new guideline that's going to come out next year, in a year or so. I know one of our partners is heavily involved in it, and I had a lot of conversation with him. There are heavy discussions regarding the newer technologies, dissection stents, and so forth. And we'll talk about that in the future. Slides in this presentation in later slides. But the bottom line is endovascular treatment in complicated type B dissection and a mural hematoma. You have to treat, and that's level 1B at the SVS. ESVS is level 2A. It doesn't really matter. You have to treat those patients, either rupture or malperfusion. In terms of uncomplicated type B dissection, which is, we're going to go and discuss this heavily during this presentation. Depends how the presentation, but there's a pretty good evidence that TVAR works pretty well. TVAR works better than open surgery in terms of outcome. When you talk about chronic dissection for many years and has issues, usually either open or you have to be creative in terms of false lumen management, and a lot of times you have to do hybrid procedures for these, but open surgery is the standard of care for those patients if they're candidate. Dissection trials such as the Medtronic trial, which Captivia, what it showed 100%. What they did basically 100% coverage of the entry tear, 94% true lumen diameter either increased or stayed stable. 89% had complete false lumen thrombosis. And we're talking about the chest here. We're not talking about the abdomen. The abdomen, that is the problem with dissection, because you can treat the chest ones, but the abdominal portion of it, a lot of times either partially thrombosed or you can have aneurysmal degeneration, and we'll talk about that. But the bottom line, this trial, there was 82.5% from dissection-related mortality, and that's really a rupture. Excuse me. It's not uncommon to see rupture thoracic aortic dissection if you do a lot of dissection. In this slide, what you see, a nice presentation of the false lumen, what happened to the false lumen 5 years after stent. And as you see, the false lumen diameter either decreases or stays stable, meaning you don't develop aneurysmal dilation when you have a stent. A true lumen also either increases or remains stable in this trial, 94% of the patient. The problem with these, just treating the thoracic portion, you always have, or most of the time, not always, you have entry tear down around this area or somewhere in the aorta that you will have retrograde flow into the false lumen. So, and that would prevent this from being completely thrombosed and can also increase in size. We are going to talk about what people have been doing for these sort of things, and basically there's a lot of issues that you have to address doing this. I would not really touch on the treatment 100%, in this presentation, due to just it would be too much to take in one setting. But I will prepare for you guys a separate presentation about endovascular or open treatment of aortic dissection, thoracoabdominal aortic dissection, and that's an important thing to know as well. So you look, after 5 years, you have a partial or complete thrombosis of the false lumen, 100% of the patient, 88% or 89% of the thrombosis in the distal to the celiac. And a lot of times in this trial, they covered close to the celiac, not necessarily in the celiac, but close, about within 5 centimeters of the celiac. The abdominal aorta, if you look, 86 or 87% of these patients have partial thrombosis, but you're going to see that sometimes nothing happens in the false lumen. If it doesn't dilate immediately right away, it will stay small, and sometimes patients develop aneurysmal degeneration. Now, the uncomplicated acute type B dissection, this is the treatment for that, whether you treat it with TBAD or not, or best medical therapy. This is a heavily basically controversial. There's a lot of research going on right now, a lot of studies, a lot of people changing what we used to do, and there's a really clear change in the management. But the take-home message here, in my opinion, that there are portion of this subgroup that would benefit from medical therapy, especially the ones that have absolutely no high-risk features, and these patients may actually benefit from medical therapy. So you have to keep that in mind. But the majority of these, they will have some high-risk feature, one or two, that they would ultimately necessitate the treatment. I'm going to talk about this study because it's an old study that was done at Mass General. Mass General is a big hospital in Boston, affiliated with Harvard Medical School. And what they've done, they looked into their dissection cases from 1999 all the way to 2011. And what they found is uncomplicated type B dissection, if they're treated, they found a decrease in basically survival they found increase in survival. So when they compared patients who been treated medically, they found the mortality or the survival rate within the 5-year period is about 60%. Whereas if you treat these patients, it goes up to 60 to 76%. And that was a big finding, and was big paper at the time. This is a promoted, basically, a new trial, randomized trial that was done, and we'll talk about the INSTEAD XL trial. You should know that trial, if you do in European boards or you do in American boards, or I'm not sure in the Arab world what the emphasis on that, but that's a landmark trial that one trainee should be familiar with. So in this study, they found there's about 58% failure in medical therapy alone, if you use that. And this promoted a INSTEAD trial initially for 2 years, and INSTEAD XL, they followed those patients for another 5 years. And what they found is an aortic specific mortality, there's reduction, there's 12.4% risk reduction, absolute risk reduction. And when you look at the basically disease related problems, then you see they found basically about 17% reduction as well. These are sobering numbers. These are big numbers. When you look at the patients who have done on the right hand side of the screen, patients who had undergone optimal medical therapy alone, they found long-term, there's significant mid and long-term mortality. These patients, but they found they die more if you don't treat them with TVAR, but if you treat them with TVAR, they live longer, essentially. So optimal medical therapy and TVAR has less long-term mortality in this trial than just medical therapy alone. And that was an eye-opener. And that's a lot of patients, a lot of people who do this, they advocate to treat these patients routinely. But the bottom line is, treating these patients also is not risk-free, so one has to really manage the patient on a case-by-case basis, because doing TVAR in an acute setting or in a subacute setting, it's not just a free ride. It has its own risks, and you look at the patient basically and you decide what you want to do with each patient individually. But the data definitely is there in those two studies. When you look at the high-risk features, and these high-risk features, every patient who has one of these needs to have a TVAR. And these are refractory pain, refractory hypotension, bloody pleural effusion, and that's always mandates an immediate TVAR, in my opinion. Aortic diameter more than 4, that's used to be in the old criteria. Radiographic only malperfusion, and that's when you see a complicated dissection with a very slivered, slit-like true lumen. And these patients would require treatment, because you don't want to have that stricture, because you saw the thickness earlier, the thickness of the septum. When a dissection becomes chronic, you want to try to open that false lumen to enhance flow. These patients who have these small false lumens undoubtedly will need some intervention at some point in their life. Again, this is just a reinforcement of refractory of the high-risk features. There's multiple studies talked about that. And this, actually, I took this from... so when you look at the false lumen diameter, it's the larger the diameter, the more likely that you'd have aneurysmal dilation. And the magic number that they came up with in multiple studies is 22 millimeters. So if you have a 22 millimeter diameter here, basically you're at risk of developing aneurysmal degeneration. Also, if you have an entry tear, the dotted line at the bottom, more than 10 millimeter especially in the lesser curve, that's a high risk feature that mandates treatment, because the jet flow through that entry tear is going to be so much that will pressurize that false lumen, and ultimately is going to develop what we call is aneurysmal dilation. Excuse me. And the other thing is the aortic diameter. If the aortic diameter is 4 already, and they're talking about thoracic aneurysms should be treated in 5.5%. So if you got somebody with 4 centimeter aorta from the get-go, then that patient should be treated. Especially, most of these patients are young. Most of the dissection patients are not that old. You don't develop most of the time aortic dissection at the age of 90 or age of 80, or these patients are hypertensive, either drug users or hypertensive, or have some genetic problems. So a lot of these patient population are young patients. When you look at the aortic diameter, again, the larger the diameter, and the magic number is 4, is the more likelihood that you're going to develop basically a aneurysmal degeneration. And once you have an aneurysm of 6 centimeter in the thoracic aorta, the dissecting aneurysm, the rupture rate somewhere between 30 and 40%, depends on which study you look at. Again, we talked about the false lumen diameter, and that you look at the event-free survival. Look how dramatic. The blue dotted line, that's when you have less than 22 millimeter, and the red stair-like line on this Kaplan-Meier plot, it's dramatically increases mortality with that. When you look at the readmission, so readmission in any condition is not something that you should wonder why the patient got readmitted and whether the patient needs to be treated or not. So, for instance, if you have a woman, 40-year-old woman had a biliary colic even, and keeps coming to the emergency room, so you have to treat that. The same thing here. If you have someone who had chest pain from aortic dissection and they keep coming to the emergency room, these patients need to be treated. So you have to treat these patients based on readmission. That would decrease cost, would decrease risk of strain on healthcare, and also, because a lot of times what happens, you admit these patients to the ICU, and you start pulse therapy. We talked about that in the last presentation for IMH and PAU. Pulse therapy is to keep systolic blood pressure less than 110, and essentially, I would say also the heart rate. It's important to keep the heart rate low. I know here in the United States we use Azmalol drip, which is a beta blocker. Also we use nicardipine or Cardine drip, which is calcium channel blocker. That both of these have a negative inotrope effect on the heart rate. A lot of countries, like in Jordan, for example, I was recently there, they don't have Azmalol or nicardipine. And that becomes challenging because what they do, nitroglycerin or nitroprusside. First of all, medication like nitroprusside you can only use for probably 48 hours at the most, because increased cyanide poisoning and things like that. But it's really contraindicated. There's contraindication to use this medication if you don't use them with beta blockers. So if you use nitroglycerin drip or nitroprusside drip, you must use beta blockers, and that could be IV metoprolol or IV any beta blockers, because what happens, these are the nitroprusside and nitroglycerins are very potent vasodilators, and they will cause a reflux tachycardia or rebound tachycardia, and that also probably will make dissection worse. So you must have beta blockers on these patients and be very, very, very aggressive. They should go to the ICU and be very aggressively monitored with blood pressure tight control. But if you're going to keep doing that every time, then that's there's a big health care cost, and also there's big morbidity on the patients. Refractory hypertension is again defined as somebody who has who takes about 3 medications for blood pressure, and the blood pressure is not controlled. In general, the importance of refractory pain and hypertension basically increases in hospital mortality. So in hospital mortality, in this high-risk group, it approaches 35% if they treat it just medically. So that's a huge, huge sobering number. So you have to be proactive on those patients, and now it's recommended that be treated. And this actually also, going back to that classification, this actually can be documented in the classification, so we'll have a coherent documentations about the patient's condition. High risk uncomplicated acute type B dissection, again we talked about that. This is a study from IRAD. IRAD is the International Registry of Aortic Dissection. A lot of hospitals in the United States and worldwide would report to them, and that data is open. A lot of people use it, and there's a lot of research came out of this data. You look on the overall in-hospital mortality rates when you treat these patients with intermediate risk group is 17.4%. If you treat these patients with just medical management, it's 35.6%. It's unbelievable. So recurrent pain and refractory hypertension are associated with increase in hospital mortality, particularly when managed medically. So the medical there's now these patients, you have to be proactive and you have to treat them, and basically this is the standard of care now. If you look at the uncomplicated type B dissection, and really, this is kind of a misnomer terminology. When you see uncomplicated type B dissection, is it really uncomplicated? Is it really, there's such a thing that's uncomplicated type B dissection? It's all complicated, but it's a relative number. So if you treat uncomplicated type B dissection medically, what they found is there's about 60 to 80% mortality in 5 years. So not mortality, survival rate. I'm sorry. Let me just back this up. So only there's survivability after treating type B dissection medically uncomplicated. So it's 60 to 80%. So that means 60 to 80% of people only survive. So that's, mortality would be 20 to 40%, which is a sobering number. Again, I want to highlight again, and I said that before, there's a small group of those that would benefit from medical therapy without stents, but that's a very small group. Once the aortic diameter exceeds 6 millimeter, rupture rate is approximately 30%. Medical therapy will help, it will delay the expansions of the aneurysm, but ultimately these patients will turn around and develop aneurysms, and if they're not compliant and then they don't show up for follow-ups and etc., then these patients will just show up to the ER one day with rupture, or if they make it even. Subsequent elective late aortic intervention are required in about 20 to 30% of patients for aneurysm expansion. So in those patients who have been treated medically. And the treatment, the chronic dissection is more complicated. There are leaks. Leak becomes not so much important in acute dissection, because really you can land, and I've done that many times, I'd land the stent very close to subclavian thrombus, and I've gotten away with it. And I'm not saying you should do that, but that's something that, it's not as important to have leak. The important is just to shut down the entry tear and basically tack that flap in acute dissection. In chronic dissection, it's a real aneurysm, and it has to be treated as such. So a lot of time these patients don't have enough landing zone, or have the steep arch or whatever, or what have you. They require different procedures for that. So This essentially we talked about. There's a lot of good. So basically, if you have one of the high risk groups, you treat that. You treat it with TVAR. There's a lot of good TVARs I'm familiar with. Bolton. Although I don't like Bolton because of the sheath and the deployment system, but Cook Alpha, Medtronic, Valiant, Captiva, and Gore, and they are comparable devices now that they really go along the aortic arch and so forth. There's a lot of good device on the market now, and this process is actually an evolution. So preoperative factors predictive of forced lumen thrombosis after TVAR. These are basically true lumen augmentation predicts forced lumen thrombosis, meaning if you place a stent and the true lumen becomes big in the visceral segment or in the thoracic aorta, you're more likely to develop true lumen forced lumen thrombosis. What does that mean is basically you will not develop an aneurysm. So complete obliteration of the forced lumen, that actually your goal. That's the aortic remodeling. Aortic remodeling is basically to have the aorta heal and get rid of that forced lumen. That what the word remodeling means. So when you look at that, and that's why people now they use a transluminal dissection stent, which is an open cell stent that you place the cover stent over the thoracic aorta, and then in the visceral segment or just distal descending aorta, you place a dissection stent and you try to tack this so you can minimize the size of the forced lumen, and that's what people have been doing, and that's what the research right now. And you'll see it in your the newer guideline. They are going to talk about that. I probably recommend it as well. So how do you define the acute dissection period? Is hyperacute is 24 hours. Acute dissection period is 14 days. Subacute dissection 15 to 92 days. More than 92 days it becomes chronic. You have to keep in mind that even at 92 days you have still elastic or plasticity in the aorta, so you can still tack it in and remodel. When you look at these graft, their freedom from aortic interventions, basically the green line is that these patients who have been treated, right here, the green line below, these patients have been treated, and you see there's a freedom from aortic intervention and ultimately survival. Retrospective analysis of the VQI, they looked at 688 patients of uncomplicated type B dissection, and they matched these cohort together. They found basically early 1 to 14 day was associated with higher risk of reintervention. So early is the aorta is friable. It's really you want to try to avoid working or performing early intervention on those patients. Sometimes you have to. Most people would intervene at 14 days. Now, if you have a lot of experience, and a lot of people now they act at 1 week even, but you have to be very, very careful. We do it here in our place in about 1 week or a little bit more than 1 week. We are very careful. We use IVUS, intravascular ultrasound. I use a soft J wire. I don't use glide wire for these most of the time, unless I can't navigate the arch or navigate the entry tear or so forth. But the glide wire, which is the Terumo 035 wire, is a dangerous wire in the wrong hand, and it's definitely dangerous in this situation, and you shouldn't use it unless you have to. If you look at the publications in type B dissections, there's a steep increase over time. 221 has 400 publications, but probably went down because at that time there was a lot of emphasis on COVID. So how these patients present, and we talked about that earlier, complicated, uncomplicated, and high risk. So the key is high risk now. And uncomplicated, you have to distinguish between these two. So uncomplicated patients who are absolutely have no high risk features, and these are very, very few. In some studies there are 20 to 30% of patients only that they can come with this type of situation. And even then, depends where you go. A lot of people are treating these based on instead XL trial and so forth. But again, treating those patients is also risky. So you don't want to just keep treating patients who don't need to be treated. But there is really a data coming up, and it's a matter of time when you're going to find that all these patients ultimately gets a stent and maybe dissection stent type of situation. So increase in the false lumen due to a retrograde flow, most commonly 78% in the thoracic aorta, 13% in the abdominal aorta, and that's still a huge number. So this also can be this size enlargement in the false lumen can be attributed to also intercostal flow. When you look at this patient, one of our patients, look at day 1 dissection. So we called him down. We repeated that in 4 days before sending him home. Then brought him back maybe a few weeks, I don't remember how long, a few weeks, a couple of weeks later. We stented him. Look at the false lumen. The false lumen is almost thrombosed. When you look at the viscerals, so you go back to look at the viscerals here, day 8. So the false lumen is wide open and it's not thrombosed. And the true lumen is small. The celiac artery comes out of the true lumen, and the false lumen is big. But you look at 8 week, at 9 weeks, basically the false lumen is almost obliterated in the chest. But the question, what happens to the false lumen in the abdomen? And that's really the key here. I'm going to talk about IVUS a little bit, intravascular ultrasound, because you see here, for example, on top right here, that's the true lumen. You see, that's when we talk about malperfusion, radiographic malperfusion. This false lumen is so small, and the round thing in there, that's the probe, the IVUS probe. And you know you are in the true lumen because the IVUS probe, that round structure there in the true lumen. So this patient was stented, and look, that false lumen has partially thrombosed. Look how he has a heterogeneous white shadow. When you look at the up there, the false lumen has black shadow, and look at the true lumen has increased in size just for stenting the thoracic aorta. This is an interesting next picture video to show you. It's very complicated, and that's why we use IVUS, because in some patients you can get in and out of the false lumen without realizing that, and if you just use an X-ray, you won't even know it. So we fortunately we don't see too many of these, but we see maybe one a year. Patient was done elsewhere without IVUS, and they have deployed one portion of the stent into the true lumen, another portion into the false lumen, and now you have a disaster essentially with severe malperfusion, a lot of times with visceral malperfusions. And we have been treating these among others as well. Other people treat it that way. Now that we have lasers, or we have, we even used to use a TIPS needle back in the day for these. But now we have laser fenestrations. We can fenestrate the false lumen. Yeah, we can wire that, and then we can extend the stent from the false lumen to true lumen, basically. So, and we've done that before on some of those patients. But luckily, we don't see this often. But if you're not careful, you can easily get into that. And let me show you this IVUS. So you are in the true lumen here. You count the false lumen. Now you're in the false lumen. You see how you come back in the true lumen. Then now you're in the false lumen. It's unbelievable how right now the round structure in the false lumen, and you see the flap where the true lumen is. So it goes back up and down, in and out of the forced true lumen if you're not doing IVUS. So you have to be very careful. And let me show you just an example of IVUS here. Look at the innominate VARE, the right left carotid subclavian, and this is what you see: true lumen, false lumen. You see the probe, the round, that's in the true lumen. Let me show you after stenting here. So subclavian, carotid, subclavian, and then the stent. And you see the stent is not fully opposed, but it's self-expanding stent. So over time, it will oppose, and this area will thrombose and remodel and heal. This is another dramatic example where you have type B dissection. This patient had a left carotid subclavian bypass. If you look at these black arrows, they're corresponding to the area of the aorta. So again, the false lumen here is bigger than true lumen is bigger than false lumen, but down in the descending aorta, you see the true lumen is it gets smaller in the abdominal aorta, or the above the celiac. Look at that false lumen, it's so small. And this after stenting. Notice on the last picture on the left hand side at the bottom, look what happened to the false lumen. You remember here was earlier was very small, now has gotten bigger after stenting. It's another dramatic example of visceral malperfusion. As you see here on the right hand side, that's the true lumen. See how small it is? That's a malperfusion, visceral malperfusion, radiographic malperfusion. Patient was fine, didn't have any symptoms. But look at that false lumen. Once we stented, look at that false lumen has gotten bigger. Not big enough, but it has gotten almost 3 times as big as what it used to. Look at that SMA and the aorta around the SMA. See the probe, the round probe is in the true lumen. True lumen is almost like a slit like a true lumen. And look how dramatically increased in size after the stent placement. And look at the renal arteries down there, where the renal arteries, that crescent-shaped black stuff there, black crescent-shaped area, that's the renal vein. And the renal arteries, you see them clearly about 9 o'clock here. And look at the true lumen after the stent placement. And these 2 dots on the left side of this slide, the 2 sides 9 and 3 p.m. 3 and 9 o'clock sides, these are the renal arteries. And around 12, the crescent shape, that's the renal vein. So it's very impressive to see this. And when you look at patients with aortic remodeling in 2 weeks, this is a false lumen, and this is another false lumen here in 2 weeks. So you look at the stent, look at the false lumen, has decreased in size dramatically, and we're talking about thoracic aorta. When you look at the abdominal aorta, so you look at the pre-stent placement, and you look, after 5 years, look what happens in the in the thoracic aorta at the level of the diaphragm and the visceral aorta. So you see there's the thrombosed false lumen, a lot of them, or partially thrombosed, but it's so big. And the true lumen, where the area is lighting up, it's very, very small. So there's oblique 3D reconstruction. And 5 years after TVAR, the above images are taken at the level of probably pulmonary vein. The false lumen almost obliterated with expanded true lumen after 5 years. The below images at the celiac axis, distal to the endograft, the true lumen here hasn't changed much. Really hasn't changed much all these years, and thrombosed likely due to complete relief of the pressurization. But that's what, again, all these examples has promoted people to think about what are we doing for the abdominal aorta, and we can see what's going on right now and what they're doing. Now, if you don't treat these patients, it's an example, 47-year-old young patient was treated medically, didn't show up, didn't follow up, and one day showed up to the ER like that with a white out left chest, had bleeding, and he had an urgent TBAD. Luckily, he survived the patient. I remember he was very, very sick for a while in the ICU, but he survived. But this lucky guy that he actually arrived to the hospital and survived rupture. So you don't want to leave these patients for chance. So if you have high-risk patients, you have to follow them. You have an uncomplicated without high-risk patients. Depends which institution, but the guidelines say, you watch them, you treat them. You have to watch them very carefully. And a lot of places, like including myself and my partners, and a lot of places, they really tend to treat most of these patients. Now, we talked about the forced lumen thrombosis and what people do, and I put this slide here for candy plug that's going to be approved, hopefully, in the US at some point. But people have done many, many things to plug the forced lumen with either candy plug if it's available, or what we've done before. Right now, what we do in the United States outside of the trial is we do not our institution, not the United States, but we do 2 AUI plugs. AUI is a aortouniiliac device. There's a plug with a device usually into the iliac artery. We use that plug, and we do 2 of them. We put them in the forced lumen. People have done glue. They placed glue, which is really crazy to me because you can embolize, because there are fenestrations and things like that. Or put large amount of coils in that forced lumen. But the idea is to prevent retrograde flow back into the forced lumen, and that's the idea here. And this picture highlights that. So you see that red arrow down, it's through fenestrations in the abdomen, feeds the forced lumen, and on top in the chest, these are the intercostal, feeds the forced lumen as well. This is a candy plug case. You look, and all these cases are done the same way. So you look in the wire navigate the forced lumen. This is lucky because the forced lumen starts basically at the iliac. You have the entry here, and you use a sheath and you deliver the candy plug, and this is the final angio. So there's stable trials that was led by Dr. Lombardi and Italy as well. A lot of doctors use this. So the stable trial is a trial where they use a covered stent in the thoracic aorta, but open cell stent, like we talked about, or dissection stent into the abdominal aorta. And the idea to tag that dissection while it's fresh, so you can remodel the aorta. And here's the example. See that the covered portion, and then at the bottom, through the viscerals, it's open cell stent. And what they found, there's 97% 1 year through 5 year decrease in or freedom from dissection-related mortality. So there's a lot of stents that can be used. When I was in training back in the day by Dr. Dietrich at Arizona Heart back in many years ago, he used to use a bronchial stent, open cell stent for these patients, but that really didn't go too far. But the same concept that you see here, and that's the concept: is you cover the entry tear on top, and then you tack with an open cell stent the visceral aorta. This is a case that we have done, and that was, I remember this case is an emergency. A patient had malperfusion with completely thrombosed left iliac artery. We did FEM. Patient was very sick, had some mesenteric ischemia as well, so we placed a dissection stent in the patient, and we bailed out because the patient was very sick, and then came back and did TVAR. But you look at the false lumen is remodeled in the abdomen when you put dissection stent, and basically you basically what happens is you tack that dissection. It's like analog. The best example I can give you is you dissect during an angiogram. You dissect the SFA, so you have a dissection flap. What you normally do, if you balloon it and you can't get rid of it, what you do, you basically place a stent. And this is the same thing. We place a stent to tack that flap and hopefully allow the aorta to heal. So this study, people have gone even further because there are two sizes of that dissection stent, 36 and 46, but sometimes it doesn't go all the way to the aorta, to the aortic wall. And people has done in this trial, in this study, basically a stabilized technique. Stabilized technique is a technique where you place a dissection stent and then place a non-compliant balloon, and very carefully you tack that stent into the aortic wall. And you have to be very, very careful because you can rupture these patients if you're too aggressive. I have seen, wasn't my patient, but I have seen one rupture, and it was very bad. These patients. So you look, it's very controlled ballooning to tack the dissection, just like you would do in the SFA. And what they found in this study, basically, if you use dissection stents, there's 81% chances of basically false lumen thrombosis and complete thrombosis. 81%, and there's a small percentage, in these patients, not small, but there's still a smaller percentage where you have the false lumen completely disappeared. And they're talking about patients without stabilized technique. When you don't use dissection stent on the left-hand side, you achieve only 57% of patients have complete thrombosis. So you see the difference. It's definitely, clearly, there's a big difference. And that's why, my partner who's on the panel for writing this guideline had multiple discussion with him about this, and basically they are going to address this dissection stent issue in the new guideline because it's just too good to ignore. We, in our institution, we use it very liberally. We use it in significant amount of cases, and we have pretty good outcome. We have modified the stabilized technique. If I get around it, I'll probably write it up, but too busy to do that this time. But the technique that we use, we measure the aorta beforehand, and we use a ZMAD balloon or gold atlas balloon, depends on the size of the aorta. We start with 3 atmosphere and kind of match the balloon into the aortic wall and not more. And we cannot go that over the areas, the entire area of the infrarenal or visceral aorta. We've had a really, really remarkable outcome with that. And look at that outcome here. This patient, you see the first picture on the right is the type B dissection with a false lumen, partially or patent false lumen, I'd say. Then see the covered stent and the dissection stent. And when you look at that several months later, this is probably 8 months later or so, you have complete obliteration of the false lumen, just using that. And I have too many examples of these. When you look at these are the area where you balloon, recommended to balloon in distal thoracic aorta, the level of celiac, and the level in the infrarenal area. But we just iron the whole thing that we do it. So, and again, you have to be very, very careful. Sometimes when I'm worried about the patient in the visceral area, sometimes I place a sheath and a wire in the visceral vessel. So this, you see the balloon here in the distal thoracic aorta. Next, in the paravisceral area, I placed a sheath and a wire in the left renal artery. Just didn't want to shut it down because it was. And I have too many of these. Look at how nice the picture is, how nice the remodel. And I have too many of these CT scans, basically. That you can see. So the stabilized technique should be used only if you have a diameter in segment 5 to 9, which is an diaphragmatic aorta. Allow complete apposition. Obviously, you shouldn't have thrombus in the area. The aorta is very tortuous. This is contraindicated to do this technique because you can rupture easily, and you have to be very careful. Yeah, you can stent with these later, but you try to avoid stenting at the same time if there is no trouble, because you want to just get in and get out. And you look at the green picture there, up on the right side, that's the stent, is not fully opposed. That's what they brought the concept of remodeling. But again, these are self-expanding stent, and you look at the left-hand side where you have a complete apposition and complete remodel of the fourth lumen. Again, as we said before, it's okay, the stent, the patient had dissection stent before and had probably some renal dysfunction. You can wire that easily through these open cells, and you can multi-layer stent or cardiasis. It's an open cell stent. It's an old concept. The late Dr. Dietrich used to hold one of those in his pocket, and it's a great concept. It has not gotten too far. It has been used in Romania, in Europe, in Ireland. It's really good stent for dissection, and there is good in the preliminary data. There's I think there's an IDE that's going to be started in the United States. I know the PI. We are going to be part of that. So basically, again, the same concept of the dissection stent. Stacking the flap. In terms of entry tears, the way how this stent works is diversion flow, or flow diversion. Flow diversion works in the brain all the time. It works sometimes in the periphery, and it's the same concept. And look at the picture with the fourth lumen. You look at 6 months, 11 months, and if you look 24 months, it's pretty impressive remodel. And if you look at this picture, you look at these are intercostal, they're all open vessels, even at 24 months, what you see. Obviously, treating these patients is not risk-free. Treatment always has risks. This is data from Mayo Clinic that shows basically there are all kind of complications in these patients associated with treatment. Therefore, treating routinely uncomplicated patient may not be the best thing in these patients. The flip side of that, when you treat the mortality, so the green one that's treated with TVAR, look at the mortality, the yellow one is decreases in those patients, aortic-related mortality. So you have to be really, the current standard, I think most people, what they do, if you have high-risk features, any high-risk features, then you treat these patients. So look at that yellow. So as the green one goes up, the green one, which is the TVAR, the yellow line goes down in terms of when you do this is a slide from IRAD study. IRAD registry, a study from IRAD registry that looks into open surgery and endovascular repair. So the dark blue at the bottom is the open surgery. You see 6.5% steadily since 2007, whereas the percentage of TVAR has been increasing. Medical management's been steady as well in the past, let's say in the past 15 years. But when you look at the outcome here for 3 years between T1 to T3, where endovascular treatment was used, there is steady, stable 3 years freedom of aortic remodeling, aortic mortality. And when you look, there's decreased hospital mortality in significant way after TVAR, stable 3 years mortality rate. TVAR increased 3 years freedom from sacral intervention. And that's true. TVAR helps when it's ending. When you look at this study from Emory, the numbers are small, but it's a good study. Look at the optimal medical management, 314 patients. Of those, half of those, almost less than half, underwent aortic reintervention while they were waiting. You look at the open surgery, 58%. TVAR, not 58%, I apologize, 58 patients, 83 patients. Definitive medical management in 173 patients. So mortality rate was 35 out of 173 patients. It's 20% mortality. It's pretty high. And overall failure rate of medical therapy was 56%, which again been reproduced with several other studies such as Mass General INSTEAD trial, Mass General reviews that done by Dr. Schwartz. Recently, Emory also expanded on their studies and what they found in terms of thrombose, the false lumen, TVAR. The overwhelming majority of their patients after TVAR, the false lumen is thrombosed, as you see on the left, on the lower left-hand side, the circle. The optimal medical therapy, partial thrombose is half, and the fully thrombosed is very minimal. 5-year survival was 91% with TVAR and 82% with optimal medical therapy. Complete false lumen thrombosis was achieved in 72% in TVARs and only in 20% in optimal medical therapy. And what does that mean? That means that basically you're going to have flow into the false lumen, and you're going to have more increased incidences of aneurysmal dilation and death. You look at this study, meta-analysis from China. They looked at a lot of parameters, a lot of studies basically looked at a lot of parameters. And what they found, the gist of it is long-term TVAR has significantly lowered the incidences of adverse event, including aortic rupture with odd ratio 0.26 it's pretty good. Reintervention rate, aortic-related death, and all-cause death compared to best medical therapy group. Again, there are certain patients who have zero uncomplicated patients that they benefit from medical therapy. Again, basically, so there's over and over multiple studies, meta-analysis showed that medical therapy alone is not good enough for these patients, especially with high-risk patients. So if you look at the what to cover now, again, I'm going to use the Emory data just because it's available. So covering patients all or close to the celiac within 5 centimeters from the celiac versus standard coverage like less than 20 centimeter graft has showed basically the difference in the false lumen thrombosis is 57 versus to 19%. So the longer you cover, the more likely that you're going to have a false lumen thrombosis. We have a data. I didn't have just time to sit, but I looked into our data. We have similar results as well, and now it would be interesting to see, because since then we've been using a dissection stent pretty much on majority of these patients, and with that you can cover less, but you can tack the entire aorta. It'll be interesting to see, but definitely covering, if you're not doing dissection stent, covering the close to the celiac would be has more beneficial effects in terms of the false lumen remodeling. I usually don't go to the celiac completely. I try to, if I can find the item cavage, ARI, and these lumbars by the just below the diaphragms. I like to keep these because knocking off these increases high risk of paraplegia in my experience. So when you look again this slide, when you look at the issues with complications, you basically, when you look at the first 24 hours, there's about 32% complication risk, retrograde dissection, and many other things. So when you do in the acute stage, it's less. Again, like we do maybe a week out, but again, if you have a lot of experience, probably you're okay. If you don't, definitely for the board, I would do some subacute stage, which is 14 days, which has 8.3% complication rate. So it's not much difference, but it's statistically significant. But it's not much difference between this and this in experienced hand. So the time in the TVAR or for acute type A dissection, and that's really a lot of people now who do this a lot go by. So if you have a acute malperfusion rupture, you do right away, except in situation where that example I showed you, patient is very, very sick, and had malperfusion, you treat that particular portion and then you fight another day, because you don't want to kill the patient. If you sometimes you do too much, you kill the patient. But at least you have to address the malperfusion. If you're in a place where you don't have capabilities of doing TVAR or anything like that, and you have acute limb ischemia, you always can do FEM, AXFEM, or whatever. You can get them out, and you can transfer them out to a place where they do that. So the other thing is, high-risk patients, so usually definitely don't treat them in the 24 hours, but less than 2 weeks on high-risk patients that we do. The magical number is about a week. We try to wait a week. If you have experience, but most the guidelines say to treat after 14 days, which and less than 90 days, which is the subacute period where you still can. And here we came up with the conclusion. So the new SVS STS classification system is an important classification to be aware of. You have to read the paper, like I said. If you have any questions about the paper, I'm happy to put a little talk about that, but it's really self-explanatory. You need to practice with different scenarios. You have to be aware of the new high-risk features. There are multiple studies showing the intervention for the below-renal devices such as dissection stent have good outcome and decreases expanding of the aorta infrarenally, and the techniques still evolving even for both open and endovascular. And then what you do if you have a patient who's asymptomatic, treatment in subacute phase likely improve early outcome with significant risk reduction in the patient. Mid-term outcome do not appear to be impacted. However, newer techniques in the need further assessment, which is, that's a point of view, but they need further assessment because they haven't been around for a long time, and these are the dissection stent and cardiasis and so forth. So we do them, but it's remained to be seen. So far, I am personally totally sold on these techniques, but really, if you scientifically speaking, you have to wait and see what happens with these patients long term. Optimal medical therapy is can still be appropriate in the right patients only. And thank you very much. If you have any questions, please feel free to ask anytime. Thank you.